Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's new with urogynecology? Find out more right now. My guest this evening is Dr. Shobha Sikka, a urogynecologist practicing here in Montgomery County. Shobha, welcome to Housecall.
Oh, thank you so much, Dr. Doman, for the invitation.
My pleasure. So briefly tell our viewers about your professional background.
Well, I went to medical school in India. I went to Institute of Medical Sciences in Varanasi in India, and I did my OBGYN residency from India as well. And then I did another OBGYN residency in Rochester General Hospital in Rochester, New York. Following that, I did a fellowship in minimally invasive GYN surgery, and that was in Utica, New York. And then I did my board certification in urogynecology. So yeah, that's my background.
Very nice.
Yeah.
And where do you practice currently?
I practice in Chevy Chase in Germantown. I have two offices, an office in Chevy Chase and another one in Germantown. And I operate mainly at Holy Cross Silver Spring Hospital.
Very nice. So what exactly is urogynecology?
So urogynecology is a subspecialty of gynecology which deals with the pelvic floor. You know, I actually got a model here with me to just show you. So this is the pelvic floor. The pelvic floor is what supports the pelvic organs, and the pelvic organs include the bladder, the uterus, and the bowel. So women come to me with various different problems involving the bladder. Many times they will come to me with urinary incontinence, which is leakage of urine, and leakage of urine can happen like on way to the bathroom. It can happen with cough, sneeze, laugh. Many times they'll come to me with different vaginal issues like vaginal dryness, burning, pain, irritation, or they'll come to me with different aspects like burning in the vulval area, urinary tract infections. Sometimes they have positive urine cultures, sometimes they have urinary tract infection symptoms, but they don't have a positive culture. They come to me with different bowel symptoms as well, and they'll come to me with fecal urgency, like they have to rush to the bathroom. Sometimes they leak stool on the way to the bathroom, which we call accidental bowel leakage. Sure. So I see a variety of symptoms in women with the pelvic floor. Many of my women come to me with symptoms happening after childbirth. Sometimes they have, many of them are what we call in their golden years, you know, as they progress through menopause, and they see a lot of symptoms related to the pelvic floor.
Sure, sure. So how common are some of these issues?
Well, they are very common. Like urinary incontinence occurs in 1 in 2 adult women.
Really?
It is extremely common. The problem is it's a social stigma to talk about it, and women don't know that medicine has advanced so much that we can treat a lot of these conditions in conservative fashion. And we have very advanced surgeries, most of which are like outpatient surgeries. They get it done and go home the same day, and can significantly help them.
Well, the fact that patients are reluctant to talk about it is the very reason why I invited you today.
Oh, thank you. My pleasure.
So how do you evaluate a patient with urinary incontinence?
So when women come to us with urinary incontinence, we actually send them a very detailed questionnaire, and which with a lot of questions like when does it happen, what are you doing to help yourself, how long it has been. So we do a detailed history, and history is extremely important because it gives us an idea why she's having the incontinence. For instance, if somebody says that they leak on way to the bathroom, they just cannot make it to the bathroom, then we know it's falling in the category of what we call overactive bladder. If somebody says that they are leaking with cough, sneeze, laugh, or when they exercise, they run, that's called stress urinary incontinence. And some of the treatments overlap, some of the treatments differ depending on the type of incontinence. So history is a very important part. Then we do a physical examination, which involves a detailed examination of the pelvis and the pelvic floor, trying to understand if there's relaxation of the vaginal walls, which can happen after childbirth. And many patients will complain of feeling of bulge, which is prolapse. Some patients will have associated fecal issues, and people are very hesitant to talk about it. So we have these questionnaires where they may feel comfortable at least marking it down, and then we bring it up and we talk about it. And then we do a basic evaluation. The evaluation involves a simple urine testing, and then it involves what we call a urodynamic study, which is a study to evaluate why the woman is leaking. And we can do a pelvic ultrasound if needed to make sure there are no masses pressing on the bladder. And we can also do a cystoscopy, which is a simple placement of a camera in the bladder to make sure there's no mass or no lesion in the bladder, which may be irritating the bladder, causing urgency sensation. So the whole evaluation is centered around what the patient's complaining of and stuff like that, yeah.
Share with our viewers some of the treatment options you alluded to treat urinary incontinence.
So depending on the type of incontinence a woman has, we go ahead with the treatment. So let's say somebody comes and says, Dr. Sikka, I just go to the bathroom 10 times during the day. I wake up 5 times at night to go to the bathroom. And sometimes I have to rush. So that sets the figure. I know that the woman is having overactive bladder. Now, this type of problem can happen in women after childbirth, but it can get worse as the woman ages. So what happens is I usually start off with very conservative management in many of these patients after I have ruled out like anything important. So we'll do a cystoscopy, make sure there is no mass, no lesion in the bladder. We will do an ultrasound, make sure there is nothing pressing on the bladder. We'll do a urodynamic study. So that will tell us the bladder capacity. So they'll tell us how much urine the bladder can hold. So normally, a bladder can hold like half a liter of urine. So if somebody's bladder can hold only 200 cc's, it's a smaller capacity bladder, which is predisposing to women going to the bathroom more frequently. So I start them off many times with what we call like pelvic floor therapy, mild electrical stimulation of the pelvic floor. The pelvic floor is a big muscle right here. It works very hard when we have children, and it needs to be rehabbed. It's just like if you play tennis and you have pain in your shoulder, you go to a therapist, like a physical therapist, right? Similarly, you can rehab the pelvic floor. So we do weekly sessions of pelvic floor rehab or mild electrical stimulation of the pelvic floor. And I tell women to get like 6 to 8 sessions and then do like one session every 2 to 3 months. And then if the woman is postmenopausal, I'll start her on vaginal estrogen. Mm-hmm. Vaginal estrogen is very helpful. If you see here, the bladder and the vagina, they actually develop very in close proximity to each other, and so they both have estrogen receptors on them. So when you give estrogen, it actually helps the bladder calm down as well. So combination of vaginal estrogen along with pelvic floor rehab can help a lot of patients. I will also start them many times on some overactive bladder medications, there are several medications which are anticholinergic, and there are some newer medications there as well, which can calm down the bladder. But I tell women I don't want to be on medications for a long period of time. Many of my patients are already on a lot of medications. And so we see how they do initially with conservative management. And I'll tell you that about 60 to 70% patients with overactive bladder will respond well to conservative management. Now, if patients say that, I don't want to take the medication long term, then what I can do is so the bladder is like an organ. It's an organ, and it's like a room. I tell my patients it distends, as it gets filled. So I can inject Botox inside the bladder, and
Botox like they use for wrinkles.
Yes, the same Botox. It's covered by insurance for this purpose. It works like magic, So as long as women do not have recurrent urinary tract infections, and as long as they empty their bladder well, they are very good candidates for bladder Botox injection. It's a simple injection. It's done with patients awake. We just instill local anesthesia through a catheter into the bladder and let them sit for 20 minutes, and then we inject Botox. It takes like 5 minutes to inject the Botox. They come in, get it done, go home, and it can last from anywhere from from 3 months to 12 months in a patient. So many times I'll receive a phone call, Dr. I'm due for my next Botox. You know, it works really well. In some patients, it also helps with pelvic pain. But I see a huge improvement in overactive bladder symptoms. Then in some patients in whom you know, they're not candidate for bladder Botox or they're looking for more long-term options, then we can go ahead and do something called peripheral nerve evaluation. So, I mean, this is really modern medicine. It's like a test driving a car, you know, before you buy it. So you can put leads down the back and you can, in the office, and attach a battery to it, send them home. They try it out for 3 to 4 days, and if it makes a huge difference, like more than 50% improvement in their urinary symptoms, then we take them to the hospital, put a small pacemaker, like a bladder pacemaker, like a small battery, and it can last for 15 to 20 years.
That's a neurostimulator? That's
a neurostimulator. That's what's called a bladder neurostimulator. It can help with both fecal incontinence and urinary incontinence.
How interesting. I'm sure our viewers are wondering, if somebody has overactive bladder, are there any dietary things that can be done to help?
Oh yes, oh yes. So, you know, I forgot to mention, so we do a voiding diary for these patients. So I have to have them document like what they are drinking in terms of fluids and how many times they're going to the restroom. And so what we are trying to assess is the caffeine intake, alcohol intake. These are two important things to keep in mind because they can stimulate the bladder. And you know, I usually tell people if you drink 1.5 liters of fluid a day, that's fine, but just try to stay away from coffee and alcohol if you can. Yeah.
Does stress cause any of this?
Anxiety, yes, we see anxiety as a important cause, especially in my younger patients, like my 20-year-olds who come to us with going to the bathroom all the time. It's very important to make sure that, you know, there are no underlying anxiety issues which may be predisposing to overactive bladder.
So if somebody has stress urinary incontinence, would you consider something for anxiety or depression or counseling?
No, stress urinary incontinence means when you leak urine with cough, sneeze, laugh.
Right.
You know, so
not literally stress.
Yeah, not literally stressed, right? But stress itself, or especially anxiety, can cause more time going to the bathroom more times, which is overactive bladder. But when we say stress urinary incontinence, that stress refers to intra-abdominal stress. Like when you cough, you increase the intra-abdominal pressure, right? So that type of increase in leakage is called stress urinary incontinence.
What is the role of vaginal laser in these conditions?
Vaginal laser is a modality which has been around for a couple of decades, and it can be used for helping the vaginal epithelium. So as we get in menopause and beyond,
the epithelium, I should
epithelium
explain,
is the lining. Right,
okay.
right. So, so this is the vagina, and inside the vagina is the epithelium of the vagina. So when we use the vaginal laser, we use it inside the vagina, and it's just like an ultrasound probe, and we rotate it in the vagina and we treat the vagina. The vaginal laser beams actually heal the vaginal mucosa, make it much more lubricated, make it much more healthier. So it has a role in patients with in whom we say they have genitourinary syndrome of menopause. Means they have a thinner vaginal wall, they have more atrophy there, so they have pain with sex, they get repeated infections, both vaginal and urinary tract infections. So and interestingly, it also calms down the symptoms of overactive bladder. And it also helps in some patients with stress urinary incontinence to calm down the symptoms of cough, leaking with cough, sneeze, laugh, but there are other options for that as well.
Very good. We're going to pause briefly for a public service announcement. More with my guest, Dr. Shobha Sikka, in a moment, and we'll be discussing urogynecology.
Where did the time go? Somehow I lost all those years. Where did the time go? I don't know how I got here. Oh, how did I get here?
done the hard part. You quit smoking. Now do the easy part and get scanned for lung cancer. If you smoked, you may still be at risk, but early detection could save your life. Talk to your doctor and learn more at savedbythescan.org.
We're back. Topic tonight is urogynecology, and my guest is Dr. Shobha Sikka. Shobha, tell us more about the surgical approaches to treat stress urinary incontinence.
Yes. So Dave, stress urinary incontinence happens when a woman leaks with cough, sneeze, laugh, or when there's increase in intra-abdominal pressure. So women will say that we leak when we run, or when we exercise, or when we do the jumping jacks, or I jump on a trampoline, and I really want to do that with my child. I'm not able to because I leak. So we initially start them off with conservative options, which include the pelvic floor therapy. There's a special chair called the Amsella chair. It's an electromagnetic chair they can sit on fully clothed, causes electromagnetic stimulation of the pelvic floor. It's very powerful. Now, if these things don't work or don't work enough for the woman, then we can do what we call a bulkamid injection. We can do sling placement in the patient as well. So if this is the bladder here, what we do is we inject a special agent which is called bulkamid. It is actually a periurethral bulking agent. Peri means around, and urethra is the tube through which the urine comes out. So this is the bladder. This is the urethra through which the urine comes out to the outside. So what we do is we do a special injection, and the injection which is most popular right now is called bulkamid. It got approved by the US FDA in 2019, and interestingly, it's 95% water and 5% polyacrylamide gel. So it's very safe. And we can do it under local anesthesia, or sometimes just under propofol, like mild sedation which you get at colonoscopy. And you just inject the bulking agent around the urethra. You go through the urethra and just inject it there. It takes like 5 minutes to inject it. And the durability data on this is from Europe. It's 7-year durability data. And it works very well. It can be re-injected up to 5 times. It's very safe because it's 95% water. So, a lot of women have a problem of leakage with cough, sneeze, laugh after childbirth. So this is a phenomenal approach to helping them.
Sure.
Then we can also put a sling. A sling is a piece of polypropylene mesh, which is a permanent material, and that goes right below the urethra, between the urethra and the vagina. So it is, again, a very simple, short procedure, but it does involve placement of a polypropylene mesh, which is like a plastic there. And in patients who don't respond to the bulkamid, or patients who have more severe certain types of stress urinary incontinence, may be a good candidate for the sling placement.
Sure. So what predisposes women to get frequent urinary tract infections, UTIs?
Yes, good question. So women get predisposed to UTIs usually when the estrogen levels in their body fall. And so many women will get a lot of urinary tract infections as they get into menopause or they are postmenopausal. And unfortunately, I have younger women who have been on chemo, especially after breast cancer or so, and they have lost ovarian function, and they're in their 40s or late 30s, and they're menopausal that early, and they come with really bad recurring urinary tract infections. So when urinary tract infections happen, it is because the estrogen helps the bladder and it helps the vagina. Because embryologically they develop in such close proximity to each other, the bladder and the vagina, that when the estrogen level falls, the microbiome in the vagina also changes. Every organ has its own microbiome, right? And the microbiome in the vagina changes because the pH in the vagina is no longer acidic. So as the microbiome changes, it is hypothesized that bacteria from the vagina or even from the anal canal can populate the bladder, and it can predispose women to urinary tract infections.
So how can women therefore prevent UTIs as they get older?
So when women have urinary tract infections, we start them off with some simple things first. We start them off with D-mannose. So D-mannose is a supplement, just like mannose, sucrose, lactose. It's a supplement, and it can be taken orally. And it has been shown in studies to significantly help prevent urinary tract infections. So basically, in the bladder, there are receptors inside the bladder for the bacteria to bind, and it seems like D-mannose competitively binds these receptors, so that it prevents the bacteria from binding there. Similarly, cranberry, people have been drinking cranberry juice for a long time, and cranberry has been studied, and there are certain supplements of cranberry which have like 36 PACs of cranberry, which has been studied to effectively help urinary tract infections. So many times I'll start patients out with just simple things like D-mannose and Utiva, especially if they come to me with a couple of incidents of UTI, and if they are menopausal, I'll start them on vaginal estrogen. It's important to know that vaginal estrogen comes in different forms. So there is a form in which it comes as a ring. It can come as a ring which can be placed inside the vagina. It also comes as tablets which can be placed, or a cream which can be placed in the vagina. So it depends on whatever the patient's comfortable with. With patients with urinary tract infections, I really like the vaginal ring because it stays in for 3 months. So it's not patient dependent. It's very safe. Patients can put it in. Our office can help them put it in. And it stays in for 3 months, so it maintains a certain level of vaginal estrogen, and vaginal estrogen is very protective in preventing urinary tract infections. So a lot of patients can be helped just with D-mannose or Utiva and vaginal estrogen. We can do laser in these patients as well. Vaginal laser can help change the microbiome to a more healthier microbiome in the vagina, which also prevents urinary tract infections. If these things are not effective completely, then we go on to either giving them a low dose prophylactic and antibiotic for like 2 or 3 months. We can also give them like certain antibiotics like fosfomycin or some other, and then I get infectious disease involved. If patients are having some of my older people will get into the hospital with these infections, and we have to keep them away from the hospital. So then I work very closely with infectious disease. We can instill gentamicin in the bladder directly, like intravesical installation of gentamicin every week for a few weeks for some of these patients. So depending on the extent of the problem, we have different solutions for them. Yeah.
Going back to the cranberry juice potential role, how does that work?
We don't know exactly how it works, but just drinking the juice by itself is probably not enough. That's why you have the concentrate, the tablet, which has that certain amount of cranberry. So when people say I just drink the juice, I usually tell them just switch to the tablet, And we don't know how it works, but there's research out. It also helps prevent post-operative urinary tract infections in our specialty, and it helps prevent urinary tract infections in general.
So if you put somebody on estrogen supplement, by whichever vehicle you utilize, do you in addition have them use the cranberry tablets?
Oh yeah, all the time, all the time. And I always tell my patients, don't worry about the risk of breast cancer or risk of other estrogen. People are very afraid it may cause breast cancer, or it may cause increased risk of heart attacks or stroke or something because they're getting estrogen. Because vaginal estrogen acts like a local cream. It mainly helps the vagina and the bladder. Very little goes into circulation. It has been extensively studied, so it's not like taking an oral pill of estrogen. It's not like putting a spray of estrogen here. It is something very localized for the vagina and the bladder.
Let's shift gears now to discuss fecal incontinence.
Sure.
What are the causes of that in patients?
So patients come to me with fecal incontinence, that is leakage of stool, either liquid stool or solid stool, and it can happen after childbirth. It can also happen with aging, and women with diabetes or certain GI disorders like inflammatory bowel diseases are more predisposed to it. Now, should you want to go ahead with how we evaluate and treat them? Okay. So when women come to us with this problem, first of all, they're extremely embarrassed. They are extremely embarrassed. It is a big social problem, especially women who have like significant accidental bowel leakage. They can just lose a bowel movement without notice. It's a huge social problem. So in these women, we do again a full history and examination. We can evaluate them. Evaluation may include a study called anorectal, which we actually put like a balloon-like catheter in the anal canal. We measure different parameters there. It gives us an idea of how we can help them. And then we can do special biofeedback, ARM-guided biofeedback for them. And ARM-guided biofeedback is a simple conservative treatment, and that, along with pelvic floor strengthening, has been shown to be extremely effective in a large number of these patients, depending on the problem they have. There are different protocols for fecal urgency, fecal incontinence. And it can help younger women, it can help older women. And then in some women, if these symptoms are not resolved by this, we can do the peripheral nerve evaluation. Like I was talking about the bladder stimulator, that same stimulator can be placed for fecal incontinence. And women can try it because they can do the small 3 to 4 day trial, and it can show if they're significantly helped, then we go ahead and place that.
We only have a couple of minutes left.
Okay.
And I do want to have the opportunity to discuss a very important topic, which is pelvic prolapse. Tell our viewers, how common is this problem and how does it present?
This problem is extremely common. I tell women that when let's say I examine a 60-year-old, I'll tell her, who has had 2 children, I'll say if I examine 100 women your age, 40% of them will have some extent of pelvic organ prolapse. And so women come to me with saying that they are very worried with that it will worsen with time, and I'll just summarize the treatments and stuff for you. So. And I tell women, don't worry, it's not an emergency, it's not a heart problem, it's a quality of life problem, and it can vary from just like mild relaxation of the pelvic floor to bulges, like something bulging out. So the treatment options are pessary placement, which is like a small ring. They come in different shapes and sizes, can be easily inserted, women don't even feel it. And the other option are surgical options, which now is minimally invasive surgery. They can be done vaginally. We can support the vagina to strong ligaments in the pelvis, and we can also sometimes put a mesh which can attach to the sacral promontory. It's a permanent mesh which can support the pelvic floor. So we do have a lot of conservative options, mainly in forms of different shapes and sizes of pessaries, along with pelvic floor therapy and surgical options.
Is the surgery done through an incision, or is it done laparoscopically?
So surgery is done either vaginally, so we're using the natural orifice, no incisions on the abdomen, and it can also be done laparoscopically or robotically. So depending on the extent of prolapse, patient's age, type of prolapse, etc.
Dr. Sikka, thank you for a wonderful interview.
Thank you so much for the invitation.
My thanks to Dr. Sikka for a very informative, important interview. My thanks to my team here at the studio. And finally, my thanks to you, the viewer, for welcoming us into your home. If you have any questions, you can reach me at the website posted on the bottom of the screen. We look forward to seeing you next time for another edition of Housecall. Good evening.